in my mind, are new standards. So my first question for Dr. Grothe is, any patient that has peritoneal-only metastatic disease, so you see a 58-year-old woman who comes into your clinic and she's got peritoneal, she's got omental disease and large peritoneal nodules, maybe she has some obstruction. Should that patient, after several months of chemotherapy, go to cytoreductive surgery? Because I think to confuse HIPEC with cytoreductive surgery alone is something that you can do if you quickly look at the study. But if you look at it, as you showed, 41.5 months, I think, was the median overall survival for CRS, for cytoreductive surgery without HIPEC.
So first of all, you said something important. You first need to test the stability of this peritoneal-only disease by giving chemotherapy. So if a patient with peritoneal disease, you give chemotherapy, you really validate the patient is not getting kind of completely out of control. It doesn't come up with, let's say, organ metastasis. Otherwise, those patients should be presented to an experienced surgeon, peritoneal surgeon. And I do believe that optimal cytoreductive surgery can prolong the patient's lives. I mean, we don't have, this is not intervention versus no intervention. This is HIPEC versus no HIPEC after optimal cytoreductive surgery. So these are select patients, of course. But 51 months is something you cannot underappreciate. That's 6 years of survival, more than 4 years of survival. And so something that I would definitely encourage is discuss the patients with experienced peritoneal surgeon. And HIPEC probably doesn't contribute too much. I think that's something we should, but it doesn't mean that we don't need the surgeons. We need the surgeons to provide optimal debulking surgery.
So don't throw the baby away with the bathwater.
Exactly. And there's something we need to reassure our HIPEC experts. They are needed because they do the surgery. Just chemotherapy, when you kind of expose the peritoneum to local chemotherapy, that probably doesn't work.
Okay, and then Dr. Garrido, I think the point for me and the question that I have for you, so you have a 72-year-old fit gentleman with a head and pancreas tumor that's clearly resectable right up front. Is neoadjuvant chemotherapy, in your mind, the standard of care, even if he's ready to undergo a Whipple?
Yeah, that's a great question. As you know, in our institution, it is. So we offer neoadjuvant chemotherapy to any patient with pancreatic cancer, even if they are resectable. The SWOG trial enrolled patients with, it was a trial for patients with resectable disease, just comparing two different backbones of neoadjuvant chemo, gemabraxine or FOLFIRINOX, right? So it's not, there's a lot of institutions that support this approach now. The NCCN guidelines still have the wording that for resectable patients, surgery up front is a standard. But because of all those reasons that I mentioned, I think that this is a systemic disease. Patients are going to die because of metastatic disease, and the sooner you address micrometastatic disease, likely the better for the patient. Plus, now we have this Preop study that, of course, it uses a different strategy, but validates the approach of neoadjuvant versus adjuvant in this setting. So, in my mind, no question about it.
What is your standard pre-neoadjuvant regimen?
So the question is, what's the standard pre-op regimen for those of you in the back?
Yeah. So there's no standard, but obviously a small percentage of patients, roughly 20-25% of patients will be fit for FOLFIRINOX. Most of the patients are better able to tolerate gemabraxine. We don't have that data in the neoadjuvant setting, but in the metastatic setting, we know from the National Cancer Institute of Canada that when patients present to a clinic, roughly 25% of them meet eligibility criteria for what was the PRODIGE study in the metastatic setting with FOLFIRINOX. 50% of them meet eligibility criteria for the MPACT trial with gemabraxine, and roughly 25% of them are very frail and are better treated with supportive care or single-agent gemcitabine if you want to offer some.
How about pre-op radiation?
Great question. So if it's resectable...
The question is about pre-op radiation.
If it's resectable, I don't think there's a role. I think that there's a lot of variability among institutions. As you know, there's not a single trial that have shown benefit of radiation compared to no radiation in the adjuvant setting in pancreatic cancer. The European trial, the SPAC1, was a negative trial, has been heavily criticized from US because of concerns about the quality of radiation. There's a US cooperative group trial in US, RTOG, that showed some benefit from chemoradiation with gemcitabine, but that trial did not have a control arm without radiation, so you cannot use that trial to support using radiation. Plus the other trial that is often quoted, which is the gastrointestinal tumor study group from 1985, was a trial where patients after surgery had chemoradiation and then 2 years of 5-FU compared to no treatment. So it's hard to use that trial when those patients are getting 2 years of 5-FU, and we have randomized trials that have shown improvement in survival with 5-FU compared to no treatment. So the benefit from that gastrointestinal tumor study group was likely due to the 2 years of 5-FU rather than radiation. We use radiation if we have a patient that have abutment of the SMA right after induction chemotherapy to try to increase the chances of having an R0 resection. But if patients are resectable, I think neoadjuvant chemo followed by resection is the way to go.
Question?
I have a question for Dr. Grothy. So much has been going into microbiome research, as you mentioned, especially with CRC. There's interest. What is the utility of this in the clinic? Are we looking at microbiome as a biomarker, or potentially transplanting from transplantation from responders to non-responders? How do you see this developing?
So the question was, what's the implication of microbiome right now in clinical practice? Nothing yet, and that's the problem. I mean, we're just, as I said, scratching the surface. There's a lot of data that's accumulating right now in various different tumor types, not just in oncology, actually. There's differences in outcomes in cardiovascular disease based on microbiome. It's something that is exploding right now in knowledge on a preclinical in, let's say, epidemiologic setting. Now, a lot of the bacteria that we identify in the microbiome are actually not yet being, let's say, cultivated in petri dishes. They're being identified through DNA methodology. So we have a whole nomenclature of a kind of microbiome genome, more or less, of bacteria that we just don't understand yet, and not the interaction apparently with biological systems like our body. Now, when you look at in all honesty, I would have, about 5 to 10 years ago, when things came up with microbiome, whatever, I personally did not believe that this would impact anything clinically relevant in the future. We need prospective studies to do that. We need prospective studies to see that by modulating the microbiome, we really change outcome in patients, not retrospective studies that show, certain microbiomes are correlated with different responses to therapy. So we need to see whether we can actually intervene and change this outcome. Then the question, of course, is can we prevent, or can we kind of generate the optimal microbiome in patients? I've seen data, your microbiome changes as soon as you eat mayonnaise, for instance, in a very bad way. Whatever we understand about microbiome, you can push it, and these changes come rapidly by our nutrition. Now we have, and this of course is conjecturing, but we have this increase in younger patients getting colorectal cancers. You will see the incidence of colorectal cancer increasing in patients under 50, under 40. And our genetic makeup hasn't changed. Hasn't changed. What has changed is our environmental exposure to nutrition and whatever you think about it. And the best way to think about this is that our nutrition interacts with the microbiome, the flora in our gut. And I think this is all found in our gut, not flora. And it's probably whatever it is. And so in the end, that's something which I believe will see major changes in how we approach not just cancer therapy, cancer prophylaxis, but body health. And I sound like a holistic alternative medicine doctor now, but that's probably right. We ignored this, too long.
We got a question here. Did you have a question? Yeah.
So a question for Dr. Grothy. You mentioned at the beginning of your talk this concept of sequential therapy. Does sequence matter? I think that in our practice, the oxalic platinum neuropathy is a big problem for quality of life, and we tend to always use that first. Should we be moving the FOLFOX later in the sequence?
Yeah. So sequence is interesting because there are, if you talk about prospective data, there's actually a trial in France which tries to kind of test 3 lines of sequence compared to different sequence. And these trials are normally destined to fail because there's so many variabilities that are introduced from line to line to line of therapy, physician decision, toxicities, etc. You can never predict or prescribe 3 lines of therapy. So I think there are 2 issues to that. I feel comfortable using oxaliplatin as first-line treatment because I think I know how to deal with the toxicities, prevent toxicities. I do not initially, I normally stop after 8 cycles, 4 months, like what you said, and then use a maintenance therapy approach. And I don't reuse oxaliplatin until very later lines of therapy. I don't reintroduce it right away. So it's more like your personal experience, how you handle things. I would not want everyone to say, oh, everyone needs to use irinotecan first line, because there are some patients who really crash on irinotecan with grade 4 diarrhea right up front. So oxaliplatin is a safer regimen in this regard, but has the cumulative toxicity as a major issue. So it's more like your knowledge on how to treat these patients, your comfort level, and really interacting with patients about toxicities and quality of life. I do believe it's safe to use oxaliplatin up front and still keep patients alive for many years with limited toxicity.